Dear colleagues, welcome to our December dialogue. As you know, dialogues are Socratic conversations among auditors with authors and reviewers and readers, all the protagonists of the European Art Journal. It has been a very successful year for the European Art Journal. The impact factor is 39.3. It almost doubled during the last 3 years. And also the number of downloads increased in the last 3 years. About 6 million 3 years ago, and now 8 million per year. So remarkable increase of IF, which is a matrix which reflects the interest of authors in the journal, and also downloads, which reflects the interest of the readers in the European Journal. But not only IF, not only top science, we also had a large number of joint sessions in the main congress around the globe. In the last few months, I chaired a joint session at the Medical Heart Association, at the national meeting of the Chinese Society, and the national meeting of the Indian Society. So the ambition of the journal is to be present not only in Europe and in US, but in the 5 continents. And we have this nice series of dialogues. I remind you that they are live streamed in Twitter and in YouTube, and then they are posted forever in both platforms, YouTube and Twitter. So if you don't have time today, you can go back to our dialogue in the future. Today is a very important dialogue, not only because it's the Christmas dialogue, but also because, and mainly because, I am surrounded by 4 wonderful ladies. They're all editors of the European Art Journal. You can see they are smiling. Cecilia Linde, Lale Tokgözoglu, Teresa Lopez Fernandez, and Tybjærg-Hansen. So thank you to all of you and for participating in this dialogue, which must be very interactive, will be interactive not only among us, but all of you are invited to join us with questions. You can ask your questions via chat, or you can raise your hand and you can ask your question personally. You can speak within the dialogue. So please be with us and contributing to the success of the dialogue. Today, as we did 1 year ago for the Christmas dialogue, our editors will review the most important papers we published in the last 12 months, the papers which are contributing to this really very high impact factor in specific fields of cardiovascular medicine. We will start with prevention and then cardio-oncology and failure. And now it's my privilege to ask the first 2 speakers, Anne and Lale, to start with prevention, and in particular, the interesting papers we published in the field of dyslipidemias. Anne will mainly focus on Lp(a) and triglycerides, and Lale on LDL. It's been a very interesting, fascinating year in dyslipidemias, many trials and new ideas and new proposals. So it will be really interesting to listen to them. After the presentation of each paper we publish in the European Art Journal, we will have a short discussion among us, but mainly with all of you. So if you have questions, again, raise your hand or write your question in the chat. Now we are ready, and I ask Anne to start with the important papers we published in the field of dyslipidemias, and in particular dealing with triglycerides and Lp(a). Anne, please.
Thank you so much, Filippo, and good afternoon to all of you out there. As Filippo said, I'm going to focus on triglyceride-rich lipoproteins or remnant lipoproteins and on lipoprotein (a). So first, to make sure that we are on the same page here, triglyceride-rich lipoproteins are chylomicron remnants, very low density lipoprotein remnants, and intermediate density lipoproteins in the non-fasting state, and VLDL remnants and IDL in the fasting state. Remnant cholesterol is the cholesterol content of the triglyceride-rich lipoproteins, and it's this cholesterol content, so not the triglycerides, that causes the atherosclerosis associated with these particles. Remnant cholesterol can be very easily calculated from a standard lipid profile as total cholesterol minus HDL cholesterol minus LDL cholesterol, but can also be measured directly, and most people, they use an assay by DENCA. So this leads me to the first paper, which is on triglyceride-rich lipoproteins, or more specifically, it's called Elevated Remnant Cholesterol, Plasma Triglycerides, and Cardiovascular and Non-Cardiovascular Mortality. And the first author of the paper is Benjamin Wadström. The study aim was to test the hypothesis that elevated remnant cholesterol and plasma triglycerides are associated with increased mortality from cardiovascular disease, cancer, and other causes. The take-home message of the paper was large randomized trials should investigate if remnant cholesterol-lowering therapy without concomitant increases in LDL cholesterol or apolipoprotein B reduces all-cause and cause-specific mortality in addition to atherosclerotic cardiovascular disease. Now, the reason for this is that the three trials on triglyceride lowering so far, only one of these lowered all of these parameters, and that was reduced, while the other studies, strength and prominent, elevated either LDL alone or LDL and ApoB. So the background here is that remnant cholesterol, we know from genetic studies, is causally associated with atherosclerotic cardiovascular risk, and that there are many trials, clinical trials ongoing now that aim at lowering remnant cholesterol and or triglycerides with the aim to lower cardiovascular risk. Benjamin Wadström, he used the Copenhagen General Population Study. This is a prospective study, and it included about 90,000 individuals who were 20 to 69 years at baseline and were followed for up to 13 years. And he looked at whether high remnant cholesterol during follow-up was associated with cause-specific mortality. And in the results, he compared remnant cholesterol levels at or above 1 millimole per liter, and that's 22% of the population, versus individuals with values below 0.5 millimoles per liter, or 19 milligrams per deciliter. What he found was that for cardiovascular mortality, the risk was, the hazard ratio was increased more than twofold. For cancer mortality, risk was not increased at all, so hazard ratio around 1. And for other mortality, there was a doubling again in the hazard ratio. He then looked into in an exploratory analysis of the causes of death, the main causes of death. So for cardiovascular mortality, the main cause of death was ischemic heart disease with a hazard ratio and it's called triglyceride-rich lipoprotein remnants, low-density lipoproteins, and risk of coronary heart disease, a UK biobank study. The study first author was Elias Björnsson, and the study is based, as the title says, on data from the UK biobank. Now, this is, I think, a very intriguing study using genetics in a new way. and the methodology is very novel, but it's also a very complicated study, so I'll not go into all the details of the study. But the aim was to investigate the relative atherogenicity of remnant particles, so triglyceride-rich remnant particles, in relation to LDL particles, and then to examine the nature of the genes influencing remnant cholesterol levels and to identify clusters of SNPs, so clusters of common genetic variants with differing effects on remnant cholesterol relative to LDL cholesterol. Now, what they showed was the main finding was that triglyceride-rich remnant lipoproteins are more atherogenic than LDL per particle, so per ApoB, because there's only one ApoB per lipoprotein particle. They did this by identifying clusters of genes where cluster 1 genes, what they call cluster 1 genes, they mainly affected receptor-mediated clearance of lipoproteins. The effect of these genes was both on LDL and on remnant cholesterol. The ratio between the remnant cholesterol to LDL cholesterol was quite low, median ratio 0.19. The odds ratio for coronary heart disease for these genes per standard deviation higher ApoB, so per particle, if you will, was 1.33. For the cluster 2 genes, these genes mainly affected lipolysis, so mainly affected the lipoprotein lipase pathway, if you will. The primary effect was on remnant cholesterol. So the ratio between remnant cholesterol and LDL was high here with a median ratio of almost 0.6. And the odds ratio for coronary heart disease was significantly higher per standard deviation, higher ApoB for this cluster, which affected mainly remnant cholesterol, and it was almost 1.8. So the conclusion of the study was that studies aimed at reducing atherosclerotic cardiovascular disease by lowering triglyceride-rich lipoproteins should reduce both remnant cholesterol, non-HDL cholesterol, and apolipoprotein B. And further, that the per particle reduction, the beneficial effect would probably be greater for remnants than for LDL because the triglyceride-rich lipoproteins per particle carry substantially more cholesterol than LDL. And now this becomes important for the design of future RCTs of triglyceride-lowering drugs, and there are many of those in development now, among these ApoC3 inhibitors and ANGPTL3 inhibitors. To move on to approach about the LPA particle. Lipoprotein little a is basically an LDL-like particle with a peculiar protein attached to it. The protein is called ApoA, and it has what's called a kringle structure. Now, LPA is completely different from other lipoproteins in the sense that levels of lipoprotein little a in plasma are almost entirely genetically determined. So you don't have to worry about genetic variants. In reality here, you can just measure lipoprotein little a. Because it's genetically determined, we also know directly that there's a causal relationship between high LPA levels and atherosclerotic stenosis. That is, thrombosis on top of already existing plaques, an increased risk of myocardial infarction, of aortic stenosis, and of heart failure, not surprisingly. And then for more extreme levels of LPA, also an increased risk for ischemic stroke and all-cause mortality. In the last paper here, which is called lipoprotein little a, is linked to atherothrombosis and aortic valve stenosis independent of C-reactive protein. The first author is Peter Thomas, and the study aim was to test the hypothesis that high lipoprotein a is a main driver for risk of atherosclerotic cardiovascular disease, myocardial infarction, and aortic valve stenosis, irrespective of C-reactive protein levels, so irrespective of systemic inflammation, basically. Now, why would you want to look at that? Well, part of the reason for this was that there are two much smaller recent studies. One is primary prevention study, so an epidemiological study. The other is a post hoc analysis of an RCT, which suggested that LPA was only associated with increased cardiovascular risk when C-reactive protein was high. However, the take-home message from this paper here is that there are potential benefits of lowering LPA regardless of the presence or absence of systemic low-grade inflammation as measured by C-reactive protein. These findings are clinically significant given the several pharmaceutical trials that are currently investigating whether LPA-lowering drugs will actually lower cardiovascular risk. Now, Peter Thomas, he used the COBA general population study against 70,000 individuals with a median follow-up of 8.2 years. And he looked at hazard ratios for atherosclerotic cardiovascular disease, myocardial infarction, and aortic valve stenosis, comparing the top 10% of LPA, and that is values above 70 milligrams per deciliter, versus the bottom 33%. And risk was stratified by CRP levels below 2 milligrams per liter or at or above 2 milligrams per liter. And in all these 6 groups stratified by CRP and LPA, there was an increased risk, and this risk was independent of CRP levels. There was also no statistical interaction between lipoprotein a and CRP. In this paper, they also looked at absolute 10-year risk of atherosclerotic cardiovascular disease and aortic valve stenosis. And in those with the highest risk, which were men aged 70 to 79, with CRP at or above 2 milligrams per liter and LPA at or above 70 milligrams per deciliter, the risk of atherosclerotic cardiovascular disease, that is the 10-year risk, was 34% in men and 20% in women, and for aortic valve stenosis, the corresponding values were 13 and 8%. I will conclude with this paper, and I'll be ready to take some questions.
Thank you, Anne, for your presentation. Yes, let's start the discussion. 5-6 minutes of your presentation, which is very, very, very stimulating. I can start with one question. The question is about residual risk. We know that there is a residual risk beyond LDL cholesterol, and we have well highlighted that important therapeutic targets are triglycerides and Lp(a). Regarding to treatment, what do you think is more promising, targeting triglycerides and Lp(a)?
Yeah, well, that's a little difficult to answer, but I would probably say Lp(a). But there are no trials in triglycerides, and they have not been very promising. But as I come on, so some that have focused on triglyceride lowering, but triglycerides, the triglyceride-rich lipoproteins, of course, differ. So it's important to take into account the remnant cholesterol, but also the non-HDL cholesterol and ApoB levels in these trials.
Thank you, Anne. Questions? Lale, any question from your side?
Actually, Professor Rall had a comment in the chat, and he was saying that both remnants and Lp(a) are more atherogenic per particle, but at least in the fasting state, most of the circulating ApoB containing particles are LDL. So it'll be difficult to show that reduction in remnants or Lp(a) will reduce atherosclerotic vascular disease risk. And I think this is an important comment that we need to take into consideration.
Yes, of course, because there are normally more LDL particles than triglyceride-rich lipoprotein particles. But not if you have high triglycerides, I guess.
Other question? This is really a fascinating topic, and I'm sure we will have interesting developments in the next
Yeah,
year.
can I say something? I see Dr.
Cecilia,
Delgado
please.
asks if there are any problems with too low LDL for the brain. I think this is a question that comes up also from the patients, so I think it's very important.
Yeah, no, there's no evidence from that, really.
Cecilia, Lale will focus on LDL cholesterol, so I'm sure that she will address these questions after this
Sorry.
presentation. But let's come back quickly for this residual lipidic risk beyond LDL cholesterol. Focus more on triglycerides, and what do you think are the most promising approaches? Angiopoietin, ApoC3, or what do you see in your crystal ball in addressing the issue of treatment of triglycerides?
Yeah, I think both of them so far are promising ApoC right now.
Lale, do you agree? Or do you bet on
For triglyceride lowering, ApoC3 for sure. But since angiopoietin-like 3 also affects LDL more significantly, we need to see those trials as well, because we know that inhibiting it reduces, at least in FH, homozygous FH patients, significantly reduces LDL cholesterol. So we have to see the new trials, and other angiopoietin-like 8 and others are coming up as well. So it's a whole expanding new field. So I think I would go for lowering ApoB, whichever lowers ApoB most will be the best for, at least for cardiovascular protection. But for pancreatitis, probably ApoC3 will be better.
Thank you. Okay, so the message, the bottom line is, okay, we are not happy with LDL cholesterol only. We want to target also what is beyond in the field of dyslipidemias, what is beyond LDL cholesterol, and we have these two interesting targets, Lp(a) and triglycerides and remnant cholesterol. And thank you, Anne, for highlighting so well how in the European Journal we published interesting papers highlighting these important new therapeutic targets. And now let's come back to another love of us, which is LDL cholesterol. There's life after LDL cholesterol, but LDL cholesterol remains a fundamental target. So Lale, can you tell us about the papers we published in this field in the last year?
Thank you so much. Good afternoon, everyone. So I'll focus on LDL because it's causal for atherosclerotic vascular disease, and it's the primary lipid target in the dyslipidemia guidelines. And we had several interesting and important papers published in our journal and others on this topic. Now, one paper which I found very interesting addressed whether transiently achieving very low LDL levels will have a legacy effect. This was a post-hoc analysis from the Odyssey Outcomes trial. You'll remember that Odyssey Outcomes, the original trial, randomized more than 18,000 patients with recent acute coronary syndromes to elranatamab or placebo to see whether MACE was reduced on top of standard lipid-lowering therapy. It was a positive trial. Now, in this post-hoc analysis, the authors examined 730 patients who achieved very low LDL cholesterol levels, below 0.39 millimole per liter or 15 milligrams per deciliter on 2 consecutive measurements. At that time, per protocol, these patients were switched blindly to placebo because it wasn't clear at that time that lowering LDL cholesterol to very low levels was safe. And I'll go back to that. The authors compared these patients with 1,460 propensity score matched patients in the placebo group. Over a median follow-up of 2.8 years, 4-point MACE occurred in 6.4% in the limited duration alirocumab group and 8.4% in the matched placebo patients. So the present analysis begins to address that a limited period of combination with high-intensity statin plus a PCSK9 inhibitor, resulting in temporary but very low LDL levels, followed by ongoing statin treatments, is associated with a prolonged reduction in the risk of MACE. And the reduction of MACE continued through the trial period, supporting the idea that strike strong and strike early is a good hypothesis. Of course, this paper has several limitations: small number of patients, post-hoc analysis, small number of events, but it's definitely hypothesis generating and needs to be explored further by randomized trials. And imaging studies of short duration are showing us that if we treat lipids aggressively, the plaque stabilizes even within 7 weeks, the fibrous cap thickens, the lipid core decreases. And to come back to the question that was asked previously today, we do know today now that lowering LDL cholesterol below 20 milligrams per deciliter is very safe, even for the brain, because we're just lowering the circulating LDL cholesterols. And most of the vital organs synthesize their own cholesterol. There were several patients who got their LDL below 15 milligrams per deciliter in the Fourier trial. They not only decreased their cardiovascular risk further, they also had no significant adverse outcomes. And we know that Fourier open label extension has a follow-up of 8.4 years, where the LDL cholesterol was a median of 30 milligrams per deciliter. So I hope that answers that question. The second interesting trial was the START-CABBAGE trial. And they tested whether statin loading before bypass grafting reduces events, because there's evidence suggesting that a high-dose statin loading before PCI may improve outcomes. So this time they tested this before bypass surgery in patients receiving long-term statins. This was a randomized, double-blind, placebo-controlled trial conducted in 14 centers in Germany, and 2,635 patients already on statins who were scheduled for bypass surgery were tested. These patients were randomly assigned to receive a statin loading or placebo, and MACE was a composite endpoint of all-cause mortality, MI, and cerebral surgery. The authors found that additional statin loading before bypass surgery, 30 days of surgery. The secondary endpoints, such as cardiac death and MI, and the area under the troponin T release, were also similar between two groups. So we can now say that, and there was another trial to support this as well, that there's no need to preload patients with statins before bypass surgery, at least for now. And the third and last paper I will focus on has to do with PCSK9 inhibition, because we know that blocking PCSK9 lowers LDL cholesterol potently. So there are several agents being developed for this purpose. Now, this paper looked at inclisiran. We know that inclisiran is a small interfering RNA, against PCSK9. And in previous studies, pooled analysis of 3 trials has been shown to reduce LDL cholesterol by 50% with only twice yearly injections. So this paper was a patient-level pooled analysis of Orion 9, 10, and 11 studies, including patients with heterozygous familial hypercholesterolemia, atherosclerotic vascular disease, or atherosclerotic vascular disease risk equivalent. These patients were all on maximally tolerated statin therapy, randomized to receive inclisiran or placebo. So these 3,655 patients received inclisiran on day 190 and 6 months thereafter for 18 months. And the composite MACE of MI, stroke, and cardiovascular death was analyzed. LDL cholesterol reduction was about 50%. And in this trial, inclisiran reduced MACE by 26% and was well tolerated except for injection site reactions and bronchitis. Of course, this is just an early insight into the potential benefits. We really have to wait for confirmation from Orion 4 trial, which is a randomized controlled trial testing the hypothesis of decreasing cardiovascular outcomes. So we'll have to wait for a year or 2 to get the results, but we can at least expect, hopefully, to get positive results with this agent as well. Now, PCSK9 inhibition is becoming so popular that there are now even 3rd generation PCSK9 inhibitors being developed. And this year, results with lerodalcibep, which is a fusion protein injected monthly, lowering LDL cholesterol by 60%, and also oral PCSK9 inhibitors were published. And even more interestingly, the first human study with CRISPR-based editing to permanently block PCSK9 gene is ongoing. So we can say that our armamentarium of LDL lowering is expanding, and we can look forward to a very interesting future. So thank you, and I'll be happy to answer questions.
Thank you, Lale, for this very interesting overview of very interesting papers we published in the last year in this important field of cardiovascular medicine. And I'm noting that there are now some questions, several questions in the audience, but please, in addition to the chat, if you have questions, you can raise your hand, physical hand or virtual hand, and you can ask the question personally. Now, there is a question from Irene Lang in particular. Is there any evidence that lipids affect VT risk, venous thromboembolic risk?
There is no clear evidence on that. There were suggestive studies, but we cannot for sure say that. Although, of course, most of the lipid-lowering agents have pleiotropic effects, antiplatelet effects, but a randomized control trial looking specifically at that has to be done.
Thank you. And then wait, questions, please.
I'm seeing Sergio. Hello, Sergio. Also reminding us about the brain cognitive function and lipid lowering. And at the American Heart Association this year, the TIMI group presented long-term data from the Ebbinghaus study looking at cognitive function and did not find any decrease in cognitive function with very low LDL cholesterol levels. So we can rest assured that at least for 8 years or so, the brain function is completely intact with very low LDL levels.
I can read another interesting question from Dr. Sedkar, which goes back to your point. Do you believe in the LDL eradication theory, LDL less than 30? I like the term eradication theory, which is reminiscent of vaccines. And I remember when Jim Brown was with us today, Jean, welcome to our dialogue, when he proposed that we can really get vaccination against LDL cholesterol with drugs like inclisiran, which can be given every 6 months. So the question is, do you believe that cholesterol eradication is the future?
I think LDL has a cumulative effect. So if we start very early on in life and lower LDL cholesterol, then the cumulative effect will be decreased, and we can completely change the trajectory of the disease. But we usually see our patients when they're middle-aged, and we know from ultrasound studies of the femoral artery and others that most of the middle-aged patients, more than half, will start having plaques. And at that point, I think it's important to lower LDL cholesterol as much as possible. And especially for someone with an acute coronary syndrome, I think going as low as possible is important. And the Fourier open label extension clearly showed that. For early primary prevention, maybe once yearly injections of a vaccine or something else to lower LDL cholesterol. But I think we should go for primordial prevention, start very early on, and stop the buildup of the plaques. Then we probably don't need to be as aggressive if we start very early on.
Lale, question from me. Let's, for a moment, believe that we can just treat our patients with the best we have, regarding of economical considerations. We have now these three classes of drugs for LDL cholesterol: statins, inhibitors of PCSK9, and antibodies, monoclonal antibodies, and RNA. Now, having the freedom of choosing the best option for our patients, regardless of economic considerations, what would be your choice?
I think
I know it's not an easy question.
No, I think we can clearly personalize therapy with all the evidence we have. So I think I would go for LDL lowering, get to target first. What agent is going to get me to target? Lifestyle plus statins, I think, are the main thing, and I think we should start with those first. But if the patient needs a significant amount of LDL reduction, especially after an acute coronary syndrome, then I would go for the agent, the PCSK9 inhibitor, that is going to give me that reduction. If the patient has a statin intolerance, we now have the choice of bempedoic acid, which is combined with ezetimibe to get a more potent effect. If the patient is very non-adherent, twice-yearly injections will be a great choice. So now we are at a point where we can choose according to the patient. And now we rely on our Sans clinic. But in the future, maybe artificial intelligence will even help us choose what drug, what patient. Even the genotypes may be important in the future. For now, we know that these drugs work for all genotypes, but we know that specific genotypes may increase statin intolerance, etc. So we are really going to personalize therapy in the future. But I think statins lifestyle will still hold on as the first step for a while, unless we have de-escalating randomized controlled trials showing that stopping statin after using a certain agent will work. But until then, they'll be the first choice.
Thank you. I'm reading other questions. Well, a comment from Sergio Kaiser pointing out, producing further evidence that low levels of LDL do not provoke cognitive impairment, but this is emerging very clearly from what we have said. And then there's a question of Lok-Fai Chiang about another interesting topic. It's not the topic for today, but I think it's interesting to mention that residual risk, okay, beyond LDL cholesterol, comments on residual risk related to inflammation, Lale?
I think it's becoming more important now that we have agents to block it. And we really have to wait for the results of the ZEUS trial, where we will check whether blocking inflammation with ziltivekimab is going to cardiovascular. But there is evidence from in these patients. So I think inflammation is very, and we have to pick out who more prone to inflammatory response in response we have. But once we pick these patients, and we know that patients with chronic kidney disease, atherosclerotic vascular disease, and others are more prone to inflammation, as well as females and others. So once we are able to identify who has a higher inflammatory risk, then I think we will be starting treating them. The CANTOS trial showed us that if a patient has high interleukin-6 levels, they can really significantly decrease their cardiovascular events on blocking interleukin. So I think it is the future that needs to be tested. We were very cautious in the prevention guidelines, and we recommended colchicine for patients with very high risk patients with atherosclerosis who did not control all their risk factors or who had recurrent events as a class 2B indication, because we don't have further evidence. But the ZEUS trial is going to answer that. And we will maybe personalize therapy even further by looking at CRP or interleukin-6 to administer anti-inflammatory therapies.
Very last short comment from Claudio Guerreiro about the importance of Lp(a) screening. This is for perhaps more for Anne, but also for you, because you published on this. Should everybody measure Lp(a) at least once in life? I think this is an important message. Lale and Anne.
Yes, I think so. I mean, that's also what the European guidelines at least suggest now.
Yes, fully agree. I mean, it's genetically determined, and although it goes up slightly after menopause in women, measuring it once is to be now. We know that if we lower other risk factors, treat other risk factors for the risk, we can benefit from measuring it once in a lifetime.
And then, of course, there are the FH patients where it's really important to measure the Lp(a) because it's...
Well, I think that this dialogue will last more than 1 hour, but I think we can afford wonderful ladies, so I think that if we go more than 1 hour, this will be well received by our colleagues. Now we change page, and another fascinating page is oncology. And the European Journal is interested in this important evolving fields of medicine. We had a joint session at the International Congress of the Oncology Society in Madrid, organized by Teresa Lopez Fernandez and Alex Lyon, who are our editors for cardio-oncology. And now it's my pleasure to ask Teresa to summarize the important papers we published in this expanding field of cardiology in the last year. Teresa, please.
Thank you, Filippo. Good afternoon, everybody. So we're going to move to this new evolving field of cardio-oncology, and I wanted to briefly summarize for you 4 articles that, in my view, or I consider are the most important European Heart Journal publication this year. So the first one refers to epidemiology. We know that in cardiovascular diseases, but we are also aware that cancer and particularly heart failure are not just linked by cardiotoxicity, but because both entities share a different pathophysiological mechanism. So in a very analysis multidisciplinary group of authors from Denmark, Boston, and the UK tried to analyze the temporal trends in new onset in patients with heart failure. So they select 100,000 patients free of cancer and 1 year after their first heart failure event, and they follow these patients for many years, try to understand the incidence in this heart failure population and what are the trends in absolute risk of cancer. So they conclude that the incidence remain surprisingly unchanged over time, and it's around 20 per 1,000 person year. And in the same line, the 5-year absolute risk of cancer remains stable from 1997 to 2016. But during this period, the most important is that we get different advances in heart failure management, and in fact, trends in survival of heart failure patients have improved a lot from 55 to 74%. So therefore, we expect a significant increase in the absolute number of patients with heart failure who develop cancer. And this is going to be an important challenge in future years. And in fact, we need to learn how to manage this population that develop cancer and has previous cardiovascular problems, and therefore needs a more special monitoring or surveillance to minimize the risk of cardiovascular toxicity. And to try to increase this general knowledge about how to manage both entities at the same time, the ESC has created a new specific curriculum for cardio-oncology that has been published at the European Journal of Heart Failure this month and is available online if you want to review it. So the next paper that I want to discuss with you is focused on radiation-induced heart disease. So as you know, the risk of radiation-induced heart disease is directly linked to the radiation dose, but also is modulated by cardiovascular risk factors and by other cancer therapies. So we include in the ESC guidelines mean heart dose as the main parameters to stratify the risk for developing radiation-induced heart disease. But this is really a very general parameter, and there is a lot of interest in the radiation oncology community to try to find which parameters are closely related with the risk of a major ischemic event. So this is a very interesting retrospective cohort study that includes over 2,000 breast cancer women from Taiwan, and all of them were treated with modern radiotherapy techniques that, as you know, had led to really significant reduction in the radiation dose to the heart. So they follow these patients for around 8 years. Most of the people receive concomitant anthracycline therapy, and 50% of these women had left breast cancer. And the main result is that 4% of this population develop a major ischemic event during an 8-year follow-up. And authors analyze as main predictors of this major ischemic event not only the mean heart dose, but also different cardiovascular risk factors, particularly chronic kidney disease and hypercholesterolemia. But the most important finding of this article is a new parameter. It's a quite complex for us as cardiologists to understand, but the parameter is LVV25. That means the percentage of the left ventricle that receive more than 25 grays. And when these parameters, LVV25, is over 4%, there is a very high risk of developing a major ischemic event in this woman, even if the mean heart dose is not very high when we analyze the full radiation therapy. So this is very important because we really need to find find good strategies to stratify the risk of long-term cardiovascular toxicity, because if not, we are not going to be able to manage this large population of cancer survivors. Another interesting paper that I want to discuss with you focus on CAR-T therapy. As you know, CAR-T is a revolutionary form of cancer immunotherapy, and is generally linked to the development of cytokine release syndrome. This is the main adverse event of people that receive CAR-T therapy. And cytokine release syndrome, because of this big inflammation that occur usually in the first 48 hours after a CAR-T infusion, is also related with several cardiovascular side events, particularly heart failure, acute myocardial infarction, or cardiogenic shock. So in a multi-center registry, authors include 200 patients that receive anti-CD19 CAR-T therapy, and they analyze predictors for severe cardiovascular events. 16% of patients develop severe cardiovascular events. Most of these events are heart failure, but some patients develop acute myocardial infarction or cardiogenic shock. So probably one of the most important messages of this article is that these cardiovascular events really impact overall mortality, and particularly non-relapse mortality of these patients. So if we really need to work on the prevention of this event and on finding what are the predictors that can help us to implement a more strong surveillance, or to implement some preventive strategies in these patients. And authors found that the peak levels of interleukin-6 just after CAR-T infusion are, along with protein C-reactive and troponin, the best predictors for a severe ischemic event and the best predictors for mortality after CAR-T therapy. So if we really took the main message that this cardiovascular events confers an increased risk of mortality in patients after CAR-T therapy, we really need to work on the specific prevention strategies. As you may know, the treatment for cytokine release syndrome is the infusion of tocilizumab, which is an anti-interleukin-6 agent. So it makes sense that people who develop higher levels of interleukin-6 are those at higher risk, and probably we need to consider in these patients to increase or to administer tocilizumab earlier to prevent this adverse event. And the last paper that I want to discuss with you is about exercise therapy. We are all aware that physical activity and exercise therapy improves cardiovascular outcomes in many cardiovascular diseases. But what is not clear is how exercise therapy impacts or reduces the risk of cardiovascular toxicity. And in fact, it's quite difficult to find good randomized trial in this area, because cancer is a very complex process with different treatments that can influence the physical activity of the patients. So this is a very elegant trial led by Jessica Scott at Memorial Sloan Kettering Center in New York. And they randomized 158 patients into 4 groups of exercise. Some of them were referred to usual care, so just an advice to do exercise during cancer therapy. Another group is randomized to a specific exercise therapy during chemotherapy for a maximum of 20 weeks. Some of them are randomized for sequential exercise. That means 20 weeks of exercise after chemotherapy. And the fourth group is referred to continuous exercise. That means exercise therapy during and after chemotherapy. So the first endpoint is to assess the differences between a concurrent and sequential exercise in terms of improving a cardiovascular function that is assessed by the evaluation of cardiorespiratory fitness using a pulmonary stress test. And unfortunately, the primary outcome was negative. So neither concurrent nor sequential exercise resulted in significant benefits in terms of cardiorespiratory fitness improvement. But as a secondary endpoint, authors analyze the effect of continuous exercise, and they really found a very robust data that continuous exercise is what really increased the cardiorespiratory fitness of patients with cancer. And probably this exceeds current recommendation for physical activity in our patients. So to consider to incorporate these cardio-oncology rehabilitation programs, particularly for patients at high risk of cardiovascular toxicity, is a really important strategy that we need to implement in our daily practice. And thank you for your attention.
Thank you very much. Fascinating story. The importance of prevention also in your field, prevention of radiation injury, importance of biomarkers for early diagnosis, importance of rehabilitation. Really is a new world which is developing around cardio-oncology. I don't have a question, but a comment. For the first time, we published the guidelines for cardio-oncology. This is the first time ever. I know it's been difficult to write these guidelines because in the absence of hard evidence, many recommendations are based on expert opinion. What has been the most challenging part in writing these difficult cardio-oncology guidelines? Difficult, but important because they are massively cited and massively downloaded. But what was the main challenge from your perspective as the author?
Yeah, I think that probably the most difficult part was to set recommendation about prevention of cardiovascular toxicity, because it's really we have a lot of data about the role of ACE inhibitors or beta blockers or even statins or other lipid lowering therapies in prevention of cardiovascular toxicity, but we do not have, unfortunately, enough evidence to select the right patients that are going to benefit from these strategies. And of course, it's also hard to personalize cardiovascular monitoring, because ideally we want to perform a very close monitoring to all patients, but this is very, very impossible with our resources. So not only to personalize cardiovascular prevention strategies, but also cardiovascular monitoring brings a lot of time to really get an agreement at the task force. But we hope that guidelines serve at least as a starting point to stimulate new research.
Thank you. Excellent. I see in the audience Christophe Leclerc. Hi, Christophe. I missed your previous questions on dyslipidemias. We had many questions on dyslipidemias. But now we have the opportunity for a question to Teresa for cardio-oncology. Anything interesting you want to ask and propose?
No, thank you, Teresa, for your very comprehensive summary. I just have a question about your first paper about a patient with heart failure. I didn't catch if it was patient with heart failure with left ventricular reduction or with preserved ejection fraction. Was this both, or was it focused on reduced ejection fraction?
No, it's both. In fact, the selection criteria was 1 year after the first heart failure event, but not ejection fraction was not a selection criteria for this population.
Thank you, Teresa. the last question for you from Enrique Delgado and her colleague Yenga. What about beta blockers, ACE inhibitors, and glycosylations in the patient? What are your views about it?
I think that SGLT2 inhibitors are very promising for anthracite data. So we need more prospective data to be sure that to work these strategies in patients at high risk of cardiovascular toxicity, because if not, with modern therapies, patients who are at low or moderate risk of cardiovascular toxicity, the really risk of severe events is very low. So it's very difficult to demonstrate any advance with preventive strategies. And from classical drugs, I think that we have very interesting data that Cecilia published last year at European Heart Journal, and it refers mainly to the role of beta blockers in preventing trastuzumab-related cardiovascular toxicity or cardiac dysfunction. And I think that probably these are the most robust data that we have now, the use of beta blockers to prevent trastuzumab cardiac dysfunction.
Very, very quickly, what about global longitudinal strength? Is an echo parameter in your view, in your opinion?
Yeah, well, global longitudinal strain is a very important parameter that help us to assess cardiac function in many clinical scenarios. So the problem is that after the publication of the SUCCUR trial, it seems that GLS do not work in cardio-oncology, but I think that this is not the right method. The SUCCUR trial incorporates most of the patients included in the SUCCUR trial are patients at low risk of cardiovascular toxicity. And the SUCCUR trial compares 3D ejection fraction with GLS. So both are very reproducible echo parameters. And it's very complex to define which one is the best one. But for sure, if we compare GLS with 2D ejection fraction, GLS is more reproducible and more sensitive. So it's, in my view, a better tool to organize the cardiovascular monitoring of patients with cancer.
Thank you very much. Again, many interesting questions, but we don't take time for all of them, but please keep asking. And now we change page again, and I'd like to ask Cecilia to tell us about important papers published in the European Journal. Cecilia speaks good Italian. I also guess she speaks a bit of Latin. And the Latins were used to say dulcis in fundo, which means that sweet things are at the end. But today, everything is really sweet. Cecilia, please.
Thank you very much, Filippo. You're always so kind, and thanks to my friends and colleagues staying for my presentation, which regards heart failure. And I would just like to start by reminding what happened last year. The STRONG HF trial was published, which showed that early up titration of heart failure medication started already within 48 hours and concluded within 2 weeks, resulted in reductions of cardiovascular hospitalizations and all-cause mortality at 90 days. And that led and was included in the 2023 focus update of the 2021 ESC guidelines for diagnosis and treatment of heart failure, which now give a 1A recommendation to rapid up titration of heart failure medication. They also give a class 1A recommendation to SGLT2 inhibitors in heart failure, irrespective of ejection fraction. And they only did this then and not 2021 because the EMPEROR and the DELIVER studies had not been published yet. So that's how it works in guidelines. But I would like to go back to early institution of medication and rapid connection with the heart failure clinic by citing the Canadian study called the COACH trial. And then I'll talk something about choice of diuretics, finishing with the STEP HF trial. So in the COACH trial, which is interesting because it's very complex and it involved more than 5,000 patients in Canada, they use what they call the stepped wedge cluster randomization, meaning that in the intervention group, patients were treated according to an algorithm suggesting to physicians either to early discharge followed by very rapid connection to the heart failure clinic, or to be hospitalized and then connected to the heart failure clinic. And then there was a usual care arm. And what they could demonstrate is that within 30 days, which is when they measured the primary endpoint, there was a 12% reduction in mortality and cardiovascular hospitalizations. But that could not be demonstrated after 20 months, when the event rate was quite high in both arms, about 50%. So it probably means that this rapid connection to heart failure clinic had something to do with the early improved outcome, which is a real life, if you want, because there's so many patients here, evidence to corroborate the strong HF trial as I see it. And also important because these patients were in their late 70s and that as such represented of the heart failure patients we see in everyday life. So then the choice of diuretics. It has been tried that thiazides help in decongestion in the chlorotic trial also last year, but that was not connected to any improved outcome, and it's not included in this focused update of the guidelines. It was also tried in the EMPALS trial that SGLT2 inhibitors compared to placebo could improve diuresis and congestion, and that was shown. And now in a small trial, which only included 61 patients, the DAPA-RESIST trial, the investigators compared adding an SGLT2 inhibitor, dapagliflozin, to metolazone, which is something that we've used in severe heart failure patients over many years, in patients who were resistant to furosemide, so not sufficiently decongested by furosemide. And what they showed was weight loss of 3 kilos in the DAPA group compared to 3.5 in the metolazone group. Actually, metolazone was more efficient in lowering weight, but that resulted in more derangement of kidney function parameters such as urea, creatinine, hyponatremia, and potassium disturbances. So that it looks like the diuretic properties of SGLT2 inhibitors will help us not to use hydrochlorothiazide or metolazone in situations where we need to decongest patients, whether or not they are furosemide resistant. Coming to an important study as I see it, and I hope also some of my arrhythmia colleagues find it interesting, is the CardioMEMS trial, the monitor heart failure trial, which is a Dutch study and very interesting. The CardioMEMS, as you know, measures pulmonary artery pressures, which is a surrogate for left ventricular filling pressures. And the use of those pressures, or patients monitor them to the treating physicians from home, have been shown to reduce hospitalizations for heart failure and mortality in the CHAMPION trial several years ago. And then in the GUIDE HF trial, it had more ambiguous results, probably because of the pandemic, but also probably because they choose less severe heart failure patients in that trial that had a lot of patients in functional class 2. In the monitor, instead, they only had functional class 3 patients with the recent hospitalizations, and they all received this CardioMEMS device, and in about half of them, the values were used and patients transmitted their values every day. These patients were extremely well treated from a heart failure drug perspective and also from a device perspective with CRT and ICDs. And what they could show was a significant improvement in KCCQ symptom score, which was their primary endpoint of 7 points after 1 year, and a 44% lower risk for heart failure-related hospitalizations, which is quite impressive as I see it. They also showed that they did in fact lower pulmonary artery pressures, and that the reason probably was more adjustments of medication, primarily diuretic, either up or down titration in the CardioMEMS used arm compared to the control arm, where they only had the device but it wasn't used. There was also an increment in 6-minute walk, and there were correlations between these pulmonary artery pressure reductions and quality of life and 6-minute walks. So very impressive, I see it, especially as it was added on this device values was added on top of already very optimal medication, and still there was a benefit by using these pressures. So coming now to my final study, which is the STEP heart failure trial, is something totally different. It is HFpEF patients who are obese, that is with a BMI of more than 30, and they were randomized to receive a GLP-1 receptor agonist. They could not have diabetes, so no patients with a diabetes in this trial. They were given either weekly semaglutide injections subcutaneously or placebo over 1 year. And they could demonstrate that, again, the KCCQ was improved by 7.8 points. Weight was reduced in the treatment group by 13.3%. And that equals almost 13 kilos, because the mean weight of these patients was 105 kilos at baseline. They could also see an improvement in 6-minute walk distance and a mixed endpoint, which included CRP and hospitalizations and quality of life was also reduced. So this, of course, is not an outcome trial, but it does indicate that such a study should be done. But the results, of course, are very, very promising in this patient group, the subgroup with HFpEF or with obesity that are severely symptomatic. So just finally, just the TRILUMINATE study, which tried edge-to-edge repair of the tricuspid regurgitation, and in an open study with a comparison of not receiving that therapy in patients with severe tricuspid regurgitation. And there was rather big improvements in quality of life in those that received the repair compared to the others. But 1-year outcome data did not show very big results, and that outcome also included need for tricuspid valve surgery. So it remains to be seen what the value of such an intervention is. So I'll stop here.
Thank you, Cecilia. Brilliant. A lot of action also in the field of heart failure. And I start with a question from Dr. Jenger again. What about resistance to diuretics, acetazolamide, the thiazides, or gliflozins? What is your favorite?
That's a very difficult study. I mean, the ADWAR trial is also another very important study, which shows that the addition of acetazolamide on top of furosemide did improve decongestion over a limited treatment period, but there was some little concern about safety, and apparently it's with the ones with alkalosis seems to be more efficient. But I think for the time being, it remains to be shown how this drug works long term. But if you may, it could be one in an arsenal of several options. But I think the SGLT2 inhibitors would be the first choice if an additional therapy is needed. And that's still indicated in view of the strong HF and the guidelines telling us to institute all pillars of heart failure medications as soon as possible.
Another question, Sergio Kaiser, is the notion of mildly reduced ejection fraction doomed to extinction, is expression? Will
No, it's not.
to survive?
No, I didn't mention it, but the updated guidelines do also give indications for all the 4 drugs in the MREF patients. It's not doomed as I see it. It just represents a group with less scientific evidence. So all the recommendation that has a class 1A in the guidelines have 1B or 2B in MREF.
So for the time being, will remain with us. Perhaps
Yeah.
not forever. Nothing is forever. Okay, thank you, Cecilia. Well, let me ask one question from my side. You didn't discuss cardiogenic shock because it's another important topic, but it's not time for everything. We published this interesting paper from Tom Lucier on DPP3 as a biomarker and a potential target in cardiogenic shock. What are your feelings about this new approach they propose?
I think, Filippo, you'll have to answer that question yourself. So I must confess to not having a firm view on that.
Well, no, personally, I think it is an interesting avenue because there's good experimental evidence that this might become a therapeutic target, and as a biomarker, at least in this initial study, worked very well. Cardiogenic shock is another difficult field, and we have not been terribly successful in the past few years. But perhaps this is a new window which can open new therapeutic opportunities. Now, other questions from the audience. Well, let me give the last word to another important colleague in the audience, Jan Piek. Hi, Jan, welcome. I know that your first lab is not heart failure, but do you have questions for our 4 speakers today? From dyslipidemias to cardio-oncology to heart failure, we had really 4 fantastic lectures, very interactive. Any questions for our magnificent ladies?
Well, thank you very much for giving me the floor, dear Filippo. I thought that the presentation was in particular interesting about the new field of cardio-oncology. And I think that some of the people already raised the question, what is the most optimal treatment? Because if you're once confronted with a patient who has breast cancer, who received many medications and comes in with an impaired left ventricular function. So my question to you is, and I think it's important for a lesson for all the cardiologists, what is then the most optimal treatment? How do you start? Is it then the combination therapy, what you normally would do in heart failure, or should it be related to the underlying treatment for the oncology? What is determining? Should it fit all sizes, or is it just a refinement of a therapy based upon your oncology treatment?
Teresa,
Thank you. Yeah, this is a very important question and a very practical question. I think that the main recommendation is in patients who develop, definitely in the patients who develop symptomatic heart failure, we need to use exactly the same strategy as we use in patients with heart failure and without cancer, unless there is a specific drug-drug interaction with cancer therapy. But particularly in these patients, because we need at least temporarily to stop cancer therapy, we need to really be sure that we treat these patients as we treat general patients with heart failure, with HFpEF or with HFrEF. Probably the most difficult question is for those patients who develop a mild asymptomatic decrease in ejection fraction. This means a decrease in ejection fraction in the range of 45 to 50 or asymptomatic. And in this case, it's really important to discuss with oncologists or hematologists what is the goal of cancer therapy, what is the objective of cancer therapy, if it is a curative therapy or a palliative therapy. And when we refer to palliative therapy, maybe we refer to 10-year cancer treatment. So this is not that the patient is going to have a poor outcome in the next 3 or 4 months. And in general, if patients develop even mild reduction in ejection fraction and they need to continue cancer therapy, we tend to be very aggressive in the management of heart failure and try to use all the medications that have demonstrated improvement outcomes in the general population. Because it's very difficult to expect dedicated randomized trials for different cancer patients types.
Thank you, Teresa. Last word to Cecilia. If you want in Italian.
Grazie tanto Filippo per questa splendida sera. Crediamo che tutti abbiamo imparato molto. We've all learned a lot. So thanks to Filippo for arranging this wonderful dialogue.
Well, I translate in English from Cecilia. I think that the hour has been interesting for all of us, teaching new things to all of us. Well, now really let me thank Anne, Cecilia, Lale, and Teresa for this. Well, this is has been the longest dialogue ever, 1 hour and 20 minutes, but it has been really extremely entertaining and useful, I think, for all of us. So thank you again for your enthusiastic participations and for what you have the interesting things we have discussed with us. It's been definitely a very interesting year for the European Heart Journal. I remind you that the next dialogue will be the first in 2024, will be on the 25th of January, but this will be in 1 month. Now let's enjoy the end of the year and the new year, which is knocking on the door. We all wish you a very, very happy New Year. And thank you, all of you, for your participation. Bye-bye.